Welcome back to another episode of the Deals for Dentists podcast. I'm your host, Dr. Eric Block. Through these podcast episodes, I'll be interviewing dental professionals and companies and aim to inspire, entertain, and educate you on the best tools and technologies out there. My goal is to help make your practice and career more profitable, efficient, and most importantly, more enjoyable.
Everyone, thank you so much for joining us. And today I have such the honor and privilege to have Dr. Dave Singh, and he's zooming in from Highlands Ranch, Colorado. And Dr. Dave Singh is the founder and chief medical officer of VIVOS Therapeutics, Inc., which can be found on vivoslife.com. He's also an adjunct professor-elect at Stanford University. So, Dr. Dave Singh, thank you so much for joining us.
Thanks, Eric. It's a pleasure for me to be here today.
Now, Dr. Dave Singh, let's start talking about the whole concept of sleep disordered breathing and craniofacial sleep medicine. Can you describe what exactly is obstructive sleep apnea?
Okay, it's a very common condition, both in the US and worldwide. Typically not very well diagnosed. A lot of people don't know they even have it. All they may know is that during the daytime, they feel sleepy. They may have fatigue. They may have hypertension, high blood pressure. They may have diabetes. They might not connect that to the fact that they are not sleeping well. Now, we have to differentiate that from insomnia, which means that you can't really fall asleep, as opposed to sleep apnea. And what happens there is that whilst you are asleep, you actually stop breathing. There's these pauses in breathing. And then the body realizes that it's not getting the oxygen it needs. It briefly wakes up, takes a breath, and you go back to sleep. And that pattern can cycle throughout the night, which means that when you wake up in the morning, you really haven't had deep, refreshing sleep. And you feel fatigued and not on your best. And some people think, oh, I'm just getting old, or I'm not a good sleeper, but these are the things that can be tested for. And it's very common, both in the US and worldwide, as I said.
And this is not just like a one-night thing. This is over and over and over again throughout a person's life. Now, so what exactly is craniofacial sleep medicine?
Well, that's the new approach that we're taking. It's a novel approach. So it's a kind of a big technical word, but essentially, everyone knows about medicine, which is the profession of our physicians. And then the physicians can specialize in a field called sleep medicine. And what sleep medicine does, it looks at all the different types of sleep disorders: insomnia, narcolepsy, sleep apnea, so on and so forth. So there's a whole range of different sleep disorders. And one of those is this sleep disordered breathing, which also includes sleep apnea. And so one of the ways that is treated is either with a CPAP machine that you wear like a mask over your face and nose when you sleep at night. Number two is you could have some kind of surgical procedure to try to improve that. Number three is you could wear a device either in your lower jaw or in your mandible to keep it forwards during nighttime. Or what we could do is try to remodel the jaws, remodel the airway. And that is what we call craniofacial sleep medicine, because we're looking at both the top jaw and the lower jaw. And our target tissue actually is the airway, which is behind the jaws. And our idea is to see if we can improve that with no drugs and no surgery by wearing these devices. The idea is to say, can we get craniofacial correction? So it's not about the teeth alone, but actually targeting the upper airway, which is actually behind the jaws.
So this is non-surgical, and you're actually, for example, expanding the palatal through the palatal suture line, and actually remodeling the jaw non-surgically.
Correct. Now, if you look historically, we were told that that's a procedure that can't be done in adult cases. It's a procedure that can be done in children, pediatric cases, but not in adults. And that was because our technology, 50 years ago, 100 years ago, is not what we have today. If we go back today and look at those suture lines within the palate, within the facial region, what we find is that there are populations of stem cells. So the idea is, okay, well, let me see if I can use a device to work with those stem cells to see if I can improve, regenerate, regrow some of those tissues, not to a huge extent in terms of childhood growth, but to a smaller extent, which would have a clinical effect and a benefit in terms of breathing whilst you're sleeping at night. So that's kind of difference. There's a subtle difference, but it's quite significant clinically.
Okay, so I read your book here, and this was an amazing read. And your book had a glossary that I think was the glossary of your book was, I think, larger than my book. My book does not have a glossary right. Because you have some major medical terms there. But one of the points that you made in your book was that the PDL ligament, which we think of actually as a ligament, is not really a ligament, but more of like a suture line. Is that right?
Absolutely. And again, we've got to look at it from the historical context. When we were in dental school, we had light microscopes and we used to do histology and stuff like that, which is great because it showed you that there's a connective tissue in between the tooth root and the bone of the jaw. Great. However, you start looking at those tissues with an electron microscope, and then go a little bit further, do a biochemical analysis, and then go further to say, what are the actual macromolecules in that? And then go even further to say, what are the genes that are producing those macromolecules? You get a totally different answer. And what the answer suggests is that this junction between the tooth root and the bone is more akin to a suture. It's simply that we have sutures in our cranium and our skull. We have sutures in our face and in our palate. And one of the ideas is these sutures actually extend into the dental region and surround the roots of the teeth. Now the question you're asking me is, well, why would you have a suture there instead of a ligament? And the answer is quite simple, that the teeth have to erupt through the jawbone to get into the mouth. So if those teeth were to just erupt and then be held in place by a ligament, there would be no mechanism to allow changes to occur when your second molars, your wisdom teeth, when they want to erupt. You'd have to work with a ligament, which is not meant to change, actually holds things together. Whereas a suture, the job there, and the stem cells in the suture, the job there is to actually grow bone. Now, how is it complicated? Well, many people, both in the US and worldwide, have gum disease. So if you've got a periodontal disease, that bone regeneration capability is severely eroded to the point where you actually can get bone loss. And so I'm talking about a healthy physiological system whereby you have a healthy periodontium, the stem cells are there, and with the appropriate signaling, they can respond by making new bone, therefore behave as a suture as opposed to a ligament.
Now, and this is significant because of the fact that you can actually remodel, it's full of stem cells, and you can actually remodel and grow bone.
Correct. Now, we're not talking, huge masses of bone. We're talking about localized, smaller quantities. But, if you take a millimeter or a quarter of an inch, that is a very large space for someone's mouth. Mm-hmm. If you think about the nasal cavity, the nasal airway, a millimeter there, that's a huge amount of space. So if you said to me, I'm going to widen your palate by a millimeter, well, that same hard palate is actually the floor of your nose. It's actually the same bone. And so what I've done is I've widened the palate, but guess what? I've actually widened the nasal floor at the same time. And so if you put two and two together, if you were to inhale through your nose, you've now got a larger volume, which is going to help you with nasal breathing. And nasal breathing is one of the key points of being able to sleep soundly during the night. You don't want to be breathing through your mouth. You want to be nasal breathing. And so when we start adding these things together and add the new research findings, you start to get a slightly different picture. And it's kind of exciting because we have alternatives that we can offer our patients, perhaps for the first time.
Now, is nasal breathing is you said is a major factor? Is that because the oxygen is it's such more, I guess, oxygenated air that you're getting versus mouth breathing. Is that one of the major reasons?
Well, obviously correct that we do need oxygen. It's like the number one component for successful breathing. However, we've got tons of oxygen. If you look at the atmospheric oxygen, more than 20%. So we've got lots of oxygen. So that's not the deal. So what is the deal? The deal is getting the oxygen to the tissues. And what we do in nasal breathing is we actually pick up nitric oxide, which is a small vessel dilator. So throughout the body, the endothelium in your brain, in your gut, all of the body, in your blood vessels is producing nitric oxide. And one of the reasons is let's get this oxygen to the tissues. Now, let's say you're not nasal breathing and you're mouth breathing. That nitric oxide is not going to be readily available because the main storage site and the production site of nitric oxide is your sinuses. So you've got the maxillary air sinus, which is the biggest sinus, that produces nitric oxide. And when you nasal breathe, the oxygen goes in, takes the nitric oxide with it, delivers it all the way down to the lungs and the pulmonary alveoli, and you get excellent oxygen exchange. That's what it's about. So it's just a step further. It's a bit more subtle. And so our idea is if we change a mouth breather to a nasal breather, there should be, and actually is, a significant change in how that patient feels and sleeps.
And then you add in the more volume of air by increasing the palatal size, the palatal volume, nasal breathing. These are all factors in battling sleep apnea. Now, can you actually cure sleep apnea?
Well, I think that's a really good question. And the answer is yes and no. Okay, so the yes answer is, if you look at our kind of overall finding of our studies, if I give a round number, I would say between 25 to 30% of our patients are cured, which means that they have an AHI of less than 5. So AHI is apnea-hypopnea index. It's the severity of the sleep apnea. And if it's less than 5, it means you don't have sleep apnea. So I would say about a quarter, maybe 30% of our patients are in that category. Then we have the vast majority of patients, let's say, maybe 60%, maybe more. They are patients who improve or don't, or stay the same, but they're not to the point where, they are completely with an AHI of less than 5, okay? Now, the medical criteria for success is that the AHI, the apnea-hypopnea index, needs to be decreased by 50% and be less than 10. And so that's our second group of patients where medically they are good to go, although they have a little bit of residual disease because we don't live in an ideal world, okay? And then we have, let's say, a population of about 15%, 10 to 15%, who appear to get worse. And so you're asking me what happened there? But the answer is that those patients are complex cases. They need to be under the care of a sleep physician. They've got other stuff going on, such as neurologic conditions, metabolic conditions. They may have severe sleep apnea or maybe central sleep apnea, those are kind of patients which would not be suitable candidates for this type of therapy. So part of the thing we have to do is saying, make sure we get good patient selection, which patients are going to respond well to this therapy, and try to identify those, which I believe is, quite a large number of cases.
So a patient with a severe AHI or a severe or complex sleep apnea, then this type of treatment, they may need more treatment, or this type of treatment may not be suitable for them. But for mild to moderate sleep apnea, this is a treatment that actually could actually solve and cure their sleep apnea.
Correct. And so we are FDA approved for mild to moderate cases. Now, if we have a severe case that's unable to wear the CPAP mask, or they decline to have a surgical intervention, then we'd say, okay, we can try this therapy on you. And we actually have been successful in several cases of severe sleep apnea. However, that's not our go-to audience, if you will.
And I've heard the compliance rate with the CPAP is like 30% or less, that people just don't end up wearing them, or they don't clean them, and it's ends up just not getting used.
Yes.
Can you explain what is epigenetics?
Well, that's a great concept, because people say to me, how can you explain these changes that we're seeing in these adult cases? You didn't do surgery, you didn't use drugs. How did you produce the change? And that's the answer is, well, it's an epigenetic phenomenon. So we all know about the human genome, which has been sequenced. We know all the genes that it takes to make a human being. And those genes are designed to have a long, healthy, lifespan for a human. Now, those genes don't exist in isolation. There are environmental influences, things like food, diet, climate, light, you name it, exercise, so on and so forth. And so there's an interaction between the genes that you inherited and the environment in which those genes find themselves. And so that is the epigenetic idea, that the outcome is based on the interaction between the genes and the environment. So now that gives us a little bit of an alternative thinking. Well, if my genes didn't do the full job, maybe the environment that they found themselves in wasn't ideal. Can I go back, modify that environment ever so slightly to see if I can get, different level of expression of genes? And the answer is yes, we can probably do that. We don't have all the pathways, we don't have all the sequences and pathways that we need right now. But as a generic statement, say, if we put a device in the patient's mouth, you have just changed the local environment. And the genes that are controlling things like bone and muscle and teeth and airway, they will respond to that new signaling. And the idea is to keep on adjusting the device so the tissues end up in a better position for airway, breathing, and sleep. And so that's the epigenetic idea. Now, there's many other examples out there, but that's how we use it. I'll give you a more kind of broad example. Let's take women of childbearing age. The current medical advice is that those type of people should be on some form of folate supplementation, folic acid. And the reason is that folate is able to methylate certain genes, and by so doing, it produces healthier babies, kids that don't have spina bifida, kids that don't have cleft palate, so on and so forth. And so that's a classic example of an epigenetic interaction. We're not using folate, we're not using any drugs, we're using a device to change the positions of the jaws. And what that does, it provides a form of signaling, which is an epigenetic response.
Now, you mentioned environmental factors. Can that be such things as babies that are feeding from a bottle, or the use of a pacifier, other things such as having premolars extracted for orthodontics, all these environmental factors that our ancestors, 10,000 years ago didn't have. Are those some of the environmental factors that you're talking about?
Yes, absolutely. So it starts right from birth. That humans, by definition, are mammals, which means that our children, our babies, are ready for suckling, breastfeeding, nursing as soon as they're born. So if a baby is not being breastfed or not for long enough, a lot of things go in a slightly different direction compared to what the genome actually expected. If we put a pacifier into a baby's mouth, we start bottle feeding, we use formula instead of mom's natural milk, so on and so forth. Those are all environmental changes which the body had to then deal with. Another idea would be thumb sucking. Another example would be if a child has food allergies and they get nasal congestion, they can't breathe through their mouth, now they become a mouth breather. They can't breathe through their nose, they become a mouth breather. And so all of these environmental factors, when you start adding them all together, they can end up producing a slightly different outcome, which is far removed from the optimal idea. So an example of what would be optimal, if you look at our craniofacial region, it's pretty symmetric. We have a symmetric face, we've got symmetric jaws, and symmetric teeth. And so one of the things that we could say is that the more symmetry we have, the more healthy we will be. And actually what the studies show is you are regarded as being more attractive if you're more symmetric. So if we start removing things like, premolar teeth or wisdom teeth, that is a change from the structure that the body was anticipating. The human condition is genetically encoded for 32 teeth. And so if we're taking teeth out, the body has to say, okay, I've got to figure out a way to work with 28 teeth as opposed to 32, or even less maybe, depending on which teeth are actually extracted. So all of those are environmental factors to take into account.
And now, are these environmental factors, do they also have a major effect on the tongue, the position of the tongue, the strength of the tongue? And is that a major factor with sleep apnea as well?
Absolutely. So we think about the hard tissues, which is the bone. We talked about the jaw bones. We've talked about, the dental tissues, which is the teeth. We've talked about the airway spaces, the sinuses and the upper airway. So what's left? The soft tissues. And that's mostly muscle. And the main muscle here is the tongue. So the tongue really wants to sit on the palate. Now, let's say the palate is narrow, it's got a high vault. Then the tongue will take a low position. And then if you lie down, the tongue will slide back and actually obstruct the airway. And so we have to train the tongue to sit in the palate. The palate has to be wide enough to accommodate the tongue. The tongue has to be free and not restricted by a frenum, let's say, so it can actually move and sit into the palate. And so the idea is to have the tongue sitting in the palate, the teeth are gently in contact and occlusion, and you are breathing through your nose. That's a really good physiological rest position. And if we can achieve that during sleep, that is our holy grail.
And when some of these or multiple factors from environmental factors such as using the thumb sucking or the bottle or the pacifier, it affects the tongue. It can affect, or we have premolars extracted or wisdom teeth extracted. Do we start to develop asymmetry? And then does our body start to compensate for that? And is this from head to toe?
Correct, absolutely. So the key here is compensation. And so, let's say you've got a child or an adult who's got smaller jaws and the teeth are crowded. Well, the person can still eat, but the teeth are crowded, Unless you've got a person who's got a small mandible, so it's going to be retruded and set back. Now you've got a patient who might end up with TMJ issues and TMD. And if that jaw falls back during sleep and the tongue rolls back as well, now you've got a patient who can breathe, but they're snoring or they've got sleep apnea at night. So all of those represent compromised function. And so what we want to do is saying, okay, how do we decompensate? And the way the body grows, as you mentioned, particularly in utero, is from the top down cranial caudal. So we've got a cranial base, the brain sits on top of that. And then the maxilla is attached to the front part, the anterior part of the cranial base. And the mandible moves, articulates through the TMJ, which is essentially the back part of the cranial base. And so the cranial base gets there first and says, I need all this space for my brain. Then the maxilla develops. And if it doesn't develop well enough, the mandible, which is downstream from the maxilla, is going to be, recessed or retruded. And therefore, it just gets from bad to worse. And so the great thing is, because of our genetic potential and because of our population of stem cells, we can start to redevelop and reposition those jaws and try to address the airway issues.
Now, what was your journey and what was your eureka moment where you discovered this, or was this a long journey to where you are now?
Well, absolutely. And so my PhD was in cleft palate formation. So looking at babies and children born with cleft palate. And some of these kids, became teenagers. And because they had surgery done quite early on, their faces wouldn't grow to the full extent. So what we decided was to do distraction osteogenesis, actually surgically move the face forwards, the mid-face. And, aesthetically, the teenagers looked a lot better, there's no doubt. But then when I went back and looked at the scans, the MRI scans in those days, I saw that the airway had also improved dramatically.
Mm-hmm.
So that gave me the idea that if I could redevelop the midface non-surgically, it would have an impact on the upper airway and be a possible solution for sleep apnea. And that was my journey.
Because, osteogenic, that surgery is distraction osteogenesis. That's a major surgery, for kids to go through. Now, did you notice that there's a lot of ancestral differences in where we're born, whether I'm Caucasian or Asian? Do you notice a lot of differences in the facial structure, such as concave or class 3 skeletal relationships and different origins?
Yeah, I mean, again, that's a really good question. And so the human genome, has been sequenced. All humans have the same genes. However, because of climate, geography, migration, intermarriage, all that kind of thing, you certainly get a certain amount of gene pooling. And so generally speaking, people from Asia, North and East Asia, and people from Africa tend to have a short cranial base phenotype. If you take people from Europe, North America, South Asia, Middle East, they have a long cranial base phenotype. And so that's the two kind of categories. The cranial base gets there first, and then pretty much lays the template for the rest of the face. So I've got my little handy phrase: the cranial base sets the pace for the rest of the face. All of that rhymes, okay? So if you take an African American, for example, we would be looking, how is my cranial base presenting in this case? And what's my target? Do I want to redevelop the midface, or do I want to look at the mandible? What do I need to do? Let's take a classical Caucasian patient and say, well, it looks like the mandible, the lower jaw is recessed. I need to bring the mandible forwards. So let's take a patient with clinical class 3 malocclusion. The jaw is prognatic, okay? And they have a diagnosis of mild sleep apnea. So my question now becomes, where are you going to put the mandible? It's already protruded, in terms of the concave facial profile. Wouldn't it make more sense in those cases to redevelop the midface and catch up with the mandible and give that tongue more space, as opposed to just protruding the mandible? And so what we try to do is customize the protocol for each individual patient and not do a one-size-fits-all type of idea. And I think that's the way to go, because sleep apnea worldwide, I think there's like 9 billion people, and of those, about 1 billion is at risk of sleep apnea.
And what are some of the major factors or issues that people that have untreated sleep apnea?
Sorry, Eric, say again.
What kind of conditions? Obviously there's right. Being tired, unrested, but what are some of the major health issues with someone that's untreated?
Yes, well, again, this is how we pick up a lot of cases. So classically, it might be someone who's obese, has a high BMI, is a bit overweight. Number 2, it may be someone who has a history of hypertension, high blood pressure. It may be someone who's got a diagnosis of diabetes. In a child, it may be something like attention deficit, hyperactive disorder, or maybe even bedwetting. Or it may be someone who's cranky and doesn't really moody kind of person. So sleep apnea can, present in a myriad of ways. And the idea is to pick up the clues, thinking this, child, this adult, they have this condition which has been diagnosed, but is there an undiagnosed diagnosis of sleep apnea as well, superimposed on that we're missing? And so one of the things we can do is screening. And screening is by using a questionnaire. You can go through the questionnaire and ask various questions, and based on their response, you could say, you have a low risk or a moderate or a high risk of having sleep apnea. If you're moderate to high, how about doing some kind of sleep study, a sleep test to find out whether you have sleep apnea or not? That would be then read by a physician who would make the diagnosis and saying, this patient has, let's say, mild sleep apnea. Well, if they have mild sleep apnea, you have 2 or 3 options there, one of which is to use either a CPAP or a oral device. And so this is the informed consent. What are the risks? What are the benefits? What are the alternatives? And so this is where the dental profession can really start to work with the health of their patients, both, in terms of oral facial health, dental health, and systemic health. And so patients who are fatigued, patients with chronic pain, all of these types of patients, when you pick that up in the medical history, it's worthy of further investigation to find out, is there an underlying sleep disorder that's being missed? And if so, what can we do about it?
Now with kids, you mentioned ADHD, bedwetting, or just behavioral issues. Mm-hmm. Are they just not getting the oxygen that they need, and it's coming out in these behaviors? And are you able to treat kids fairly, I would say, a lot quicker than adults because they're still in that growing phase?
Well, I think that's a great question. And the short answer is that, the behavior and metabolism of these kids has been disrupted. The neurophysiology of the brain has been disrupted. We need these kids to be sleeping with deep sleep. And so if you look at attention deficit hyperactivity disorder, for example, about 50% of those kids, if you fix the sleep, you actually fix the ADD at the same time, and vice versa. Now, for kids, it's a bit of a special case because they've got tonsils. And again, if the tonsils are causing obstruction, well, let's think about what we have to do. We may have to do a surgical intervention. We may be able to get the tonsils to regress. And then if you actually ask the question, if you've got things like, nasal allergies, is that related to food? Where's the allergy coming from? So that this kid has got these hypertrophic tonsils, which are trying to fight off some kind of, infection or inflammation. Now, would the kids respond faster? Again, yes and no. They're in an active growth phase. And so, yes, we would expect some kind of, short-term, benefits there. But some adults also develop, pretty good. You put a device in, and the next 2 or 3 nights, they're suddenly sleeping and saying, wow, I'm dreaming again. I remember my dreams. I wake up, I'm refreshed. And so it's a patient-by-patient analysis in terms of how this patient responds. Some patients are non-responders. Non-responders means that they're not getting any better. And that is one of our main areas of research, the next level, saying, let's take the people who don't respond well and figure out what's going on with those. What's the complex medical history that's coming in to prevent that patient from, making really good progress? So again, case-by-case basis, each patient is individual, and we'll try to do the best we can for each patient as they come through.
Yeah, I didn't even, think about that patients that aren't going through the proper cycles of sleep aren't dreaming. And then now all of a sudden, with your device, they're able to get the proper oxygen and they're going through the proper cycles of sleep and they're dreaming again. That's amazing. Now, we didn't mention tongue tie. Is that a major factor with kids as well?
I think it's something that needs to be screened for. Mm-hmm. I think we're seeing children now with much more the phrene, whether they're in the tongue, the buccal phrene, in the vestibule there. We're starting to see more of this than ever before. Now, again, it may be just because we're screening and we're actually finding it, but it seems to me there may be some kind of epigenetic component where these kids are being born with kind of thicker phrene, which are, kind of tethering the tissues, if you will. So now we have to ask the question, well, how do you explain that on an epigenetic basis? Well, if you take the lingual frenum on the tongue, during development, when the tongue first develops, it's actually attached to the floor of the mouth. And then what happens is apoptosis, programmed cell death, and those cells underneath the tongue die away and the tongue isn't free to move. In the midline, a little kind of band of tissue is left there, which is the lingual frenum. Now, what if the apoptosis was deficient? Because of some epigenetic phenomenon, they would have thicker phrene or shorter phrene, and therefore you got tissue restrictions. So what we do now is saying, okay, let's make no assumptions. When a child comes to the dental office, let's screen for any tongue tie, any tongue restrictions, and just go through that procedure. And if we do identify that the tongue is restricted from moving or there's a tongue tie, the first thing we will do is oral myofunctional therapy. Let's train this kid how to use the tongue, how to position the tongue. It's just like being an athlete. Let's get your tongue in the best possible condition. Let's do that for 4 weeks. After the 4 weeks, we're going to do a review. And at that point, the dentist, the orthodontist can say, this is a good candidate for a tongue release, for a frenectomy or a frenotomy, whatever needs to be done. And then once that frenectomy has been done, let's continue on with the oral myofunctional therapy for another 8 weeks to make sure that the tongue doesn't heal back in the same position it was at the beginning. So we can't do a tongue release in isolation. It has to be coordinated. The structure of the tongue has to be coordinated with the function. And function is really muscle memory. We can train you, we can teach you. The same way a child learns how to walk, how to run, how to ride a bike, how to swim, all of that is muscle coordination. The tongue's no different. And so this is a great topic. It's a relatively easy one to get parents and kids engaged to say, let's get your oral and craniofacial health to the best it can possibly be. By these very simple procedures, kind of quite early on in some cases.
And for adults, is the scalp tongue, is that typically a sign, that the tongue is in a lower position and is resting on the lower teeth?
Correct. So the medical research shows that, if you've got tongue scalping, kind of these indentations on the side of the tongue, the crenation of the tongue, is associated with a high risk of sleep apnea. And basically what the tongue is doing is taking up whatever space is left. And the teeth are kind of in the way. And so you get this kind of wavy, kind of crenated edge to the tongue. Some people don't have that. What they have instead is tongue thrust. And so the tongue, instead of kind of lying in between the teeth, it kind of finds a new space at the front of the mouth. And now you got tongue thrust. And that becomes a habit. And so some of these patients might, present at the dental office with an anterior open bite or a anterior open bite tendency. And so these are patients where the tongue has learned not to go back, but actually to go forwards. And so when you close the anterior open bite orthodontically, if you don't correct the tongue behavior, you can get relapse of the orthodontic finish. So this is what I mean by structure and function. Let's train the tongue to take up the relevant position and provide the space to do that. And so a lot of exciting avenues to investigate that.
Now, when did everything change environmentally, would you say? And did our ancestors, they had room for 32 teeth, they breathed through their nose, their tongue rested up on their palate, they didn't snore, they didn't have sleep apnea. When did all this change?
Well, I think there's two major changes. Let's go back, 30, 40, 50,000 years. This is still Homo sapiens and modern humans. The two big events, at least in my mind, is number one is we settled down and became farmers, started growing crops, agriculture, and then controlling the environment, saying we can get everything we need in this one environment. Prior to that, there was a lot of migration that happened. If you look at the human genome, you can see how the migrations happen in waves and different parts of the world. So part one is that we became, we didn't have the nomadic existence anymore. We became agriculturists, farmers, and that became our mode of, living. Then number two, on top of that, we had the Industrial Revolution, where we changed stuff, mechanization, engineering, and with that, we got air pollution and so on and so forth. And so to me, those are the big two steps that happened in terms of how do we end up in this condition? If we were roaming the earth and not kind of dwelling in cities and towns and all that kind of stuff, there would be a slightly different impact. And if we weren't as industrialized as we were, would the environment be different? Would we be healthier people? So lots of kind of, philosophical questions come out there, or ethical questions come out there. Human longevity has increased. People used to die at, 40 years old. If you go historically, if you live at 40, 50 years old, that's like, well, that's a long life. Now you can double that, okay? and the world population has increased. I don't want to be pessimistic, but we are the new dinosaurs. We have taken over the world, and we have, displaced all the other species. It's going to take one meteoric event, and suddenly, hey, no more humans. Hopefully that won't happen. But you have to think about, you have these dominant species which were in control of the world, and suddenly they were wiped out 65 years ago. Are we the new dinosaurs? I don't know. But philosophically, you can think about how we have changed the environment so much, how we have adapted to these conditions, and how much adaptation can we still do to have longevity, survivability in the environmental conditions that we find ourselves in. The great thing is, to be optimistic, we've just had our first two, suborbital space flights. These are, quote, civilians going into outer space. And so there's going to be all sorts of changes that go on, because think about gravity. And I'm thinking of, the name escapes me now. I'm going to say Mike Collins, I might have got it wrong, the astronaut from Arizona. And so he and his twin brother, identical twin brothers, one of them went into space and the other one didn't. When they came back, they compared the genomes. And what they found is a tangible difference, a recognizable difference in the genes. And so when you change the environment to an extreme where there's no gravity, again, there are changes. And so this is an ongoing process and, futuristic. Let's see how it works out. We're optimists, and hope for the best. So let's see how things move.
Okay, good. Because, the beginning of that portion of that conversation, I wasn't going to be able to sleep tonight thinking about, being the next set of dinosaurs and being extinct. But now I feel better. Now that we can go into outer space. Now, are you talking, how much air are we talking about? Are we talking about going from a straw volume of air to a garden hose volume of air? Is that the kind of changes you're seeing?
Well, again, the numbers are to help to guide us in terms of where are we. The real deal is, how is that patient feeling? So you measure the air on a patient and it comes back as 25 cc's. You think, wow, great. And the patient says, I'm not sleeping that well. You think, that's unusual. Another patient walks in, you measure the airway, 25 cc's. How are you sleeping? Oh, God, that's the best sleep I ever had in my life. You're thinking, what's going on here? Because apart from the size, you've got to think about the functionality. And that is the muscle tone, the tonicity of the airway, the plasticity of the airway. If you've got a low airway tone, you've got a nice big pipe there, it's going to become flaccid and it's going to collapse during sleep. If you've got a small airway with a high muscle tone, it's not going to collapse. Generally speaking, that's our healthy children. They've got smaller airways with a good muscle tone and they sleep fine. Over a period of time, the airway gets bigger as they grow. If the muscle tone decreases, which we know happens with aging, there's an increased risk of sleep apnea. So the numbers are a guide, but our best guide is our clinical judgment, and our patients' bodies don't lie. If they're in pain, they'll tell you. If they're sleeping well, they'll tell you, and the reverse is also true. So do we need numbers? Absolutely. We can figure stuff out. We can make predictions. Whether those numbers actually apply to a specific patient in your dental chair, that is, that's all about the clinical expertise, experience, background, and skill of the clinician to figure that out. And so the numbers are a guide, but, there's human variation that we have to take into account.
I didn't even think about the muscle tone factor. And just everybody is just so different in how they're going to react and how their muscle tone is. VIVOS is, would you say you're out there saving lives? You're not just treating teeth. You're helping people live longer, feel better, avoid a lot of major health issues.
Absolutely. I think that, we have to be brave. You've got to have a little bit of conviction to say, we're onto something here. We make sure we get all our regulations done in every way possible. But at the end of the day, based on our experience, based on our findings of the last 10, 15 years, we believe we're in the right direction. This is the game changer. This is something that we can say, let's take a kid who is having difficulty at school with learning and issues and turn that kid around. Let's take an adult patient who is in pain or has, high blood pressure. They are increased risk of stroke, maybe heart attack. Can we decrease that risk, push that stroke 20 years downstream? And if it does happen, it's much less severe than it would have been if it was left untreated. Now, we don't have the straight answer to those questions today. However, that is the path that we're going down. The body has a remarkable potential of self-healing, self-regulation, and we want to use that healing ability, optimize it, enhance it best we can. Because if you take a patient let's say a patient who's overweight and not doing so well, okay, well, let's get you into the gym and let's start doing some workout. Let's put you on a nourishing diet that has the nutrients that you actually need. Let's fix your sleep. So now you've got sleep hygiene, going to bed at the right time, getting sufficient sleep and quality sleep. And let's put in some kind of relaxation, meditation, whatever you want, to get the mental issues under control. Let's see if we can optimize those 4 areas and get a healthier and happier patient. I mean, those are really big, ideals, but we just chip away one step at a time and let's see what we can do. And all I would say is so far, so good.
So this is, VIVOS philosophy. It's not just a mouth device. It's a whole, you're looking at the whole body and all the patient's signs and symptoms, and you're really kind of focusing on that patient and what's going on with them. And let's talk about that for a second. Let's say a patient comes into my office and they're showing some major symptoms of sleep apnea. But of course, the first thing they're going to ask, does my insurance cover this?
Right.
How does that work?
Well, again, we're going to work with that patient to make sure that we can get them, treated in whichever way possible. Long story real short is that most of the medical carriers in the US, we can name all of them, including, TRICARE and all the big ones. These procedures are covered by medical insurance, not dental insurance.
Mm-hmm.
So let's say you go to the dental office and you need to have fillings or some kind of orthodontic work. That would be your dental insurance. But if we get a diagnosis of mild or moderate sleep apnea, that's medical billing. That's going to be covered through your medical insurance. Therefore, if there's any dental work that still needs to be done, after the sleep apnea has been addressed, you've still got your dental insurance, available. So we are working very closely with the major carriers in the US to make sure that these procedures are covered. And generally speaking, I think we've been, I think we've been very successful to get coverage. We have to go a little bit further, think about, Medicare, Medicaid, all those kinds of things. We're still working on some of those aspects as well. But generally speaking, as a broad brush, I would say that these procedures are covered more or less by the medical insurance.
And does VIVOS help the dentist and the staff out with that? And also, what kind of training and support does VIVOS offer?
Well, this is the thing about VIVOS. It's kind of unique. It's like a one-stop shop. They're going to give you, for the dental, let's take the dental team. Let's take the dental professionals, whether it's a dentist, general dentist, orthodontist, whatever. They will train them. They will support them. They will go through, the screening, the diagnostics, the treatment, all that kind of stuff. But you can't do that in isolation. So the dental office staff, all of the team members need to be on board. Let's show you how to market this idea, how to make patients aware that this is going on. Patient education information, that to me is like step one. You say, okay, let's talk about this topic for the first time. Number two is the diagnostic screening part. Well, for the screening part, you go for your dental hygiene appointment. The hygienist might be the first person to say, I'm seeing a torus here in the palate, or I'm seeing tori in the mandible, and we really haven't talked about this before. That's not a coincidence. And so the dental team all starts getting involved. The patient then goes through the treatment, but the front office, the administrators, have to be aware of medical billing. And so what VIVOS does, in addition, is saying, let me train you, show you, help you, support you in terms of the medical billing side of things. So to me, there are 3 or 4 areas. Number one is a marketing area, which is patient education, all that great stuff. Number 2 is the diagnostic area, including screening. Number 3 is the device area, the actual treatment area, if you will. And number 4 is the reimbursement area, all the billing stuff. And then it goes round and round the circle. Get my next set of patients from marketing, so on and so forth. And so what VIVOS does is a lot of, I will call it hand-holding, give you confidence, give you, the tools that you need to make it easier for you and the staff to really get on board with this and own this movement in your own office, in your own practice, and help those patients who you've been seeing maybe for years and never realized that they have these health issues that are literally in your hands in terms of being able to offer a solution.
Wow. And what about being in touch with other, support from other dentists that are in the VIVOS family, I would say? Is there a lot of communication between dentists or support groups, forums or webinars and lectures going on?
Absolutely. So it's just an ecosystem and it's flourishing, it's growing, it's got all of these different components to it. It's a network. You meet people live, you meet people online, you meet people at CE events, so on and so forth. And so it's not well, here you are, thank you and bye-bye. This is a journey. This is a team effort. And if you've got a question that your team member can't answer, the chances are there's someone in the VIVOS system who's been there, done that, and got a t-shirt. So we want to be able to say, okay, how can you benefit from our experience of the last 5, 10, 15 years? We've seen these types of cases. We've seen these types of issues. We've seen so many different things. Why don't we all share our common knowledge and do a little bit of networking here, make it easier for everyone to make really good progress? So that's the VIVOS kind of philosophy in terms of you're not a one-stop shop and you're not a one-man band. You're really part of a big family that's going to coordinate and help each other out.
Yeah, I think that's so important, especially if a dentist is new to sleep and airways, is like you said, to have that hand holding, have that support. I think that's a great way to get involved, because it can be an intimidating area of treatment where I had minimal or no training in dental school.
Right.
Now, before we wrap things up, you mentioned the word journey. Throughout your journey, being involved with so much research and as a dentist and entrepreneur, what advice would you give out there to some young dentists or entrepreneurs out there?
Well, again, I will speak from experience, and the bottom line is have no fear. Go for it, because I remember going back very early on where a dentist came to me, a young dentist, and said, I can't get my office to grow. I don't have to expand it. I don't have to recruit these new patients. So I said, well, sleep apnea is one of those areas of growth. Sports medicine or sports dentistry is another area of growth. And so by putting in these components into your office, you're going to increase the number of procedures that you offer and therefore a large number of patients. Well, that same dentist came back within a few years and had opened a second satellite office. It was like, wow, this really happens. Another dentist came along. These are all absolutely people who I met and said, I have just doubled my office revenue by adding this new procedure. I could go on and on and on, but hey, these are guys who were committed. They owned it. They went out and said, I'm going to make this thing happen. And patients, what they pick up most of all is your passion, your enthusiasm. They'll say, what are you on? It's like, wow, what is this guy on? He's so excited about this thing. It must be a good thing. And that enthusiasm is infectious. They will talk to family and friends, and so you start building the office. Let's say you find a child who needs a little bit of help, and they get a good result. Well, that kid probably has maybe a brother and sister and parents. And so when those people start seeing the kind of outcomes with these types of cases, they're going to talk to each other, and you're going to start to build the practice. So I always say the only person who can stop you is yourself. You really need to say, I'm going to make this happen, and hold me back, you know?
That's such great advice. And, you know, in my book, the Stress-Free Dentist here, which just came out, I really feel that, you know, adding a new modality like this, you know, sure, it's great for revenue, and you're providing such a great service to patients, but can re-energize you. It can re-energize the practice, the staff, because if you're just doing the same old thing over and over, and you're in that hamster wheel, you're going to burn out. And if you can add something like sleep apnea and airway treatment, it's going to rejuvenate you in your practice. So, Dr. Dave Singh, thank you so much for joining us. That was an amazing interview. I hope to be in touch.
Thank you, Eric. It's a pleasure as always. I'm looking forward to seeing you again. And again, thank you so much for the invitation.